Hello, good evening, and welcome to the ASRA Pain Medicine Hot Topics webinar presentation on Entrustable Professional Activities for Residents and Fellows. I'm Chris Schroeder, anesthesiologist from the University of Wisconsin. I will be moderating the webinar here tonight. And just a little bit of a housekeeping thing to take care of before we move forward. Eventually, we will be getting to your questions, and really oftentimes the best part of these presentations are the interactive discussions that we have with all of you who are watching this at home. So as we go along, there's a Q&A box at the bottom. Please enter your questions in there. And then when you're done entering your question, please make sure you actually then click the send button then as well. So we have a number of excellent presenters here tonight. Starting with Dr. Marty. He is a senior attending anesthesiologist at the Orthopedic University Hospital, actually in Zürich right now, where it is 1 o'clock in the morning, where he is also on vacation. He is an international EPA expert and has the best title in the world as Chief Visionary Officer of Prepared, which is an edutech company that he'll be talking to you guys about. We also then have Dr. Elaine Prendiville. This is an intern also on vacation coming to you from OHSU. She was actually already very accomplished in the field of education, was a first author on a recent study that looked at specifically entrustable professional activities in regional anesthesia and acute pain medicine. We then have Dr. Stephen Porter, Associate Professor and former Program Director for Regional Anesthesia and Acute Pain Medicine Fellowship down in my second home, which is Florida. And then finally, we have Dr. Glenn Woodworth. I know him incredibly well as the father of the anesthesia toolbox, really just a wealth of knowledge and somebody who really kind of pioneered this field of making sure that we're looking at what our residents are learning and able to evaluate it. So without any further ado, then I'll turn this over to Dr. Marty, and please keep in mind as you have those questions, go ahead and enter them so that we can get to them at the end.
Great. Thank you so much for the introduction, Kristen. And I will just start with a quick foundational element so that you all know what we're talking about. And it's about EPAs, entrustable professional activities, but it's also basically about competency-based medical education. And what has already been mentioned is that my funny, self-ironic title of Chief Visionary Officer is also my disclosure. I own my own company, and we're producing tools for documenting workplace-based assessments and EPAs. But I will just briefly touch it and mostly speak of other things that are important for this session today. So let's start with a common ground. So for all us as educators, I think we all want, maybe even as human beings, we all want to be treated by people, by trainees, by specialists who actually know their job. And I'm not so sure if we actually reach that goal all the time. And we've been asking this specific questions to committee members in Europe from all different European countries. Like, is it possible in your country that you will graduate board certified trainees that you don't think that they are ready to actually treat your loved ones? So, and most of the countries said, yeah, it's possible that in our country, we have to graduate those people as well. And how's that even possible? And I think in the past, we've been measuring too many things that were easy to measure, like numbers of procedures, for example. So how many times did you do that? I mean, we all know, me, myself, I have been answering this question so many times. So every time I met somebody new, they asked me, how many times did you do that? But we all know people who are really competent after 20 procedures, and others, they didn't get it after 100. So numbers is probably not the right way to measure competence. The other easy thing to measure is time. So if we make time the constant, time in training, for example, 5 years or 3 years, competence competence will be the variable. It's not possible otherwise. So time is also not ideal because we are two individual as learners and human beings. And the other interesting thing is there are people in your environment, in mine, that are hunters of certificates. They are attending all the courses. They have certificates all over their place at home, but still they're not exactly the ones that we want to be treated by in our clinical workplace. So the holy grail is actually how to measure competence. And we had a conference about 3.5 years ago in Kuala Lumpur. It was called the Ottawa Conference, and we were a bunch of people only interested in assessment in medical education, and we drafted some consensus statements. So now we know that we should get rid of this idea that one single board exam can make sure that somebody is competent or not. We should adopt a sampling approach, which is called programmatic assessment. So we sample frequent workplace-based assessment throughout the trajectory of a learner, from first residency year to the final. We have many frequent workplace-based assessments, and then we don't make decision based on just one data point. We always need multiple data points to base our data on. I think Glenn will touch on that as well later on. And what was really happy, what I was happy about is to see that design is coming into place. Like if processes don't work, usually we have the reflex to just apply more pressure on people to adhere to those rotten processes, or make things mandatory or punish people if they don't adhere to a process. But my approach and my philosophy is also to look at the process, design it in a way that it's easier to adhere to or even fun to adhere to. And ideally, competence would be visible, so we could actually see where our trainees are. Like, for example, for judo belts, let's make an example of a green belt trainee. If I have a green belt trainee in anesthesia in front of me, maybe I still don't know exactly if this person is able to place an interscalene catheter or not. So I still need to ask, how many times did you do the interscalene catheter, or how long have you been in training? So if we have one color per person, it's not granular enough. We need a color-coded system for each individual task that makes our profession. For example, in regional anesthesia, probably every block is such a task that we need to perform. And these tasks are the EPAs. Those are the entrustable professional activities that, in a sum, makes our profession. And the cool thing about EPAs, and this is what I really love about this EPAs, is the scale that we're measuring competence is not a scale from 1 to 10, or a merit scale from A to F, for example, but it's an entrustment supervision scale. How much support, how much supervision does a trainee need to perform a task? And the cool thing about this is it's a scale that we are already using all the time, every day, but more implicit than explicit. So we kind of always think about, can I leave the theater for a coffee or for a lunch break or something like that? So we are familiar with this scale, and the only difference between now and maybe later, if we work with EPAs, is that we document those levels of supervision more frequently. And there is not just a title of an EPA, but an EPA has certain elements that are important. It's the title, description, other things. The ones that I marked in bold are probably the most important elements. So the knowledge, skills, and attitudes that are important for this EPA. So what does a trainee need to know? What do they need to perform, and what attitude do they need to have in order to perform a task independently? And to put it into perspective, we always need all three elements to perform a task. For example, if a trainee places a spinal anesthesia and is really skilled with spinal needles, knows all the anatomy really well, knows the dosages of the medications, but is rude to the patient and shouts at the patient like, make a round back and doesn't hurt that much, right? So I would rate this trainee on direct supervision just because of the attitude. And I think this is a beauty of the EPAs as well, that the attitudes become more important than before. And the question in the back of our heads is always, would I let this trainee perform this task on my mother? And suddenly attitudes are important. And the gold standard to observe or to rate an EPA is if we have a direct observation. So if you do something with a trainee, you observe the trainee and then do the rating. If you don't have the luxury to observe a trainee, you can always go for a case-based discussion. And of course, there are other elements. If you want to test knowledge, there's still a value for theoretical exams. And if you want to go more into attitudes, multi-source feedback is the way you should evaluate attitudes. So this is kind of an assessment system that covers all the different spots. And a question that we usually get if we work with EPAs is like, we've been trained differently for many, many years, and why is this better? And it's just, if you think what we're doing right now, counting numbers and maybe just counting years and hoping that every trainee is ready for independent practice is not what we actually should do. So it's better to have more data points that we can rely our decision of progression on than we have right now. And the cool thing is we can identify struggling learners earlier, and we identify not to kick them out, but to help them to grow. It's a support system that helps every learner to be at the maximum performance they are able to do. And I've never met a physician who likes administrative work. So this is where technology is coming in to really help us reduce the admin burden. And we can use apps, for example, to help with the documentation of the workplace-based assessments. So in summary, we all want to have a competency-based medical education where we know that the trainees are ready to perform the job. And how are we going to do it? With programmatic assessment. It's a sampling approach of frequent low-stake workplace-based assessments. And what we're looking at are the EPAs, for example, the tasks that they perform in the everyday workplace. And we can, of course, add other elements of assessment to the EPAs. And if we do that, if we really document the workplace-based assessment, often we add other elements of assessment, we can easily answer these questions with a clear yes, because we know at each point in time where our trainees are and how much support they need in order to have a maximum patient safety. And now I'm really happy to hear the rest of the session, and then at the end to answer your questions. Looking forward to the rest of you guys.
Thank you so much for all of that great explanation. I think that'll really give a good background to what I'm going to speak about. Let me pull this up here. So my name is Elaine Prendiville. Thank you so much for the kind introduction earlier. I also am coming from OHSU along with Dr. Woodworth, and I worked on this work that I'm going to talk about with Dr. Len Woodworth and Dr. Stephen Porter as well. So their help was very much so appreciated throughout this project, and they were definitely the guiding vision of it all as well. So basically what we did was we developed Entrustable professional activities for regional anesthesia and acute pain management training for fellows, or at least that was the overall goal. So I'm going to talk about the process. Let's see here. So at the beginning of this project, kind of where we began was assembling an expert panel. We thought that was the best place to start. And so essentially what we did was we solicited all of the regional anesthesia and pain management fellowship program directors pretty much across the whole country to assemble a panel who we could consider experts in this field. And we ended up with 20 individuals from 18 different institutions. And all of those individuals were led by a steering committee, which consisted of myself, Glenn Woodworth, and Stephen Porter. And I think the backbone of this entire project really is the Delphi method, or the modified Delphi method, that we use throughout the project. And that's kind of what we thought would be the most effective to develop consensus across this project and across the deliverable that we created with it. So just to give a little background, the Delphi method essentially is to create a survey of some kind, administer that survey to a group of people. In this case, it was to our expert panel, collect feedback on that survey, which in this case was both commentary on the survey itself, as well as the survey responses. And then the steering committee, which was the three of us, would then consolidate all of that feedback, create another subsequent survey, and survey that whole process again. And so it's really the iterative rounds of survey that we utilize to come to consensus on various aspects of this project. That was kind of how we got to our end point. For us, we defined consensus as greater than or equal to 70% of the panelists agreeing that something, in this case, one of the assessments should be kept. So that's kind of the background of all of this. And then kind of the biggest piece of the project, the biggest piece of deliverable that we wanted to create were EPAs, as were just kind of outlined to you. And so we utilized this modified Delphi method with the panel to essentially solicit a big list of potential EPAs. I believe we started with around 60 or so that the panel submitted as potential EPAs, or things that they thought would be important for fellows to be assessed on. And then we did iterative rounds of this survey until the panel came to consensus on a total of 23 EPAs. I think one interesting thing to note is that after each round, we would basically provide the panel with a summary of changes document, so that they were looped in with what was kept, what was rid of, and what was potentially modified based on their comments. So we ended up with 23 EPAs with that aspect of the project. And then, just given the nature of regional anesthesia fellowship training, we also thought it would be important to come up with a list of procedural skills. And so we solicited the panel once again, kind of in a second phase of the project, for what procedural skills they thought were both expected for fellows to achieve prior to the end of their training and prior to independent practice, and then also procedural skills that could be considered, in quotations, aspirational. So things that maybe some fellows would achieve and some would not, depending on the site of their training or what they were exposed to. So as the steering committee, we essentially just eliminated redundancies in that list and kind of consolidated it to make sure there were no redundancies. But then we actually decided not to pursue a Delphi method with the procedural skills list, just because we wanted it to be an all-inclusive list, which is somewhat dissimilar from the EPAs. Our next step in the process was, as many of you probably know, the ACGME provides these descriptive milestones for fellows to achieve prior to finishing their programs, but they don't really provide a way to determine whether or not those descriptive milestones are achieved, hence the purpose of these EPAs, or the hopeful purpose of these EPAs. So our task at hand was to map all of these 23 EPAs and procedural skills to the descriptive milestones. And so our panel actually helped a lot with this and helped do some of that mapping. And then the steering committee, so myself, Glenn, and Stephen, all came together and really worked for quite some time, sort of tuning up all of these mapping documents and just making sure there was consistency across all of the EPAs and procedural skills, and across all of the maps and definitions of the EPAs. And sort of in the process of doing that, we recognized that EPAs and procedural skills were going to leave some gaps in assessment and in covering the milestones. Specifically, they left some gaps in milestones that would be considered non-technical. So some examples would be evidence-based medicine, professionalism, and ethics and wellness, for example. So to fill that gap, we essentially adapted some situational assessments from work that was developed for anesthesia residency programs. And we presented those to the panel, and once again did a round of Delphi survey, essentially to then settle on some final situational assessments. And the consensus was to keep 7 of those situational assessments. And I'll show you what those look like on some subsequent slides as well. So once that was all said and done, really the final task of the project was to define what graduation targets would be necessary for fellows to achieve to be considered apt at these different skills and to be considered ready for independent practice. And so essentially what we did was, once again, no surprise here, we utilized a Delphi method to have the panel essentially assign graduation targets on this entrustment level scale. And this entrustment scale was introduced to you in the previous part of the presentation, thankfully, but I have it up here again on the top right of the slide, ranging from level 1, meaning the supervising faculty member actually did the skill and the trainee observed it, all the way to 5, which would be considered independent practice. In between, you have things like direct supervision, reactive supervision, and available if needed. So essentially, we did a few rounds of survey to land on for what graduation targets should be in place for each EPA, each procedural skill, and each situational assessment. So I'll bring you to my next slide here. And I don't expect you all to read all of these things. The point really is just to present to you kind of the deliverable and the final form, or the form 1.0, we'll call it, that we came up with for these EPAs and assessments. You'll notice I left out the procedural skills list because it's quite lengthy and would be quite cluttered to add to a slide. But what you can see on the left are the EPAs that we created, so the 23 that we all came to consensus on, or our panel did, I should say. They're categorized into preoperative assessment, patients with special conditions, perioperative care, regional and acute pain service, and then other. The other really being management of any complications that could arise. And then you can see on the right those situational assessments that I alluded to previously. You can see some examples here, like assessment of teaching and presentation skills, accountability, and adapting care for different patient populations. One important thing I think we did that was interesting and helpful to kind of guiding our work was this gap analysis. So this may look a bit confusing, so I'll break it down slightly, but on the left side, vertically, you'll see listed each of the milestones from the ACGME, and then across the top, you'll see each of the EPAs and the special assessments, the situational assessments, I should say, that we created. The darker the green means the more essentially coverage or applicability there was to each of these milestones. And the less you see means that the milestone was sort of checked off less. I don't expect you all to catch this, but essentially there was only one milestone that we weren't really able to cover throughout all these different assessments that we picked up on, and that was the milestone that was generates new knowledge related to procedures and techniques related to acute pain management and regional anesthesia. But otherwise, the rest were actually all covered here. Oh, I'm sorry, I'm seeing here that my slides were not advancing. Can someone let me know if they've advanced thus far, or if I need to go back?
No, no problem. I was just waiting, but you were still on the first slide, so that was my bad. Everything's fine.
Oh, okay, perfect. Thank you. Thank you so much. Okay. So that kind of brings me to my summary slide here, which is that, overall, this study involved a multi-institutional group of individuals that was tasked to create some sort of comprehensive framework, in this case, consisting of EPAs, procedural skills, and situational assessments, to essentially inform trainee longitudinal achievement of competency. And all of these different assessments were then mapped to the ACGME descriptive milestones, and graduation targets were set for each. And then they were essentially all put into a software that we used that's known kind of in this realm and utilized for competency-based assessments already, called MyTip Reports. And it both has a website form as well as a mobile app form. And currently, this entire project is going to be piloting this year at 8 different programs. And you might ask, similarly to what we heard about in the last presentation, why a mobile app for this? And I think the biggest piece that we talked about as a steering committee and just throughout the development of this project was, we were hoping to create some sort of assessment tool that was essentially a point of care assessment tool that was both useful in the moment, easily accessible, and timely. And so I think the use of a mobile application hopefully will allow for that to happen. And that is pretty much my entire presentation there. And really proud of the work that we did. Here are all of my references there, and happy to answer any questions at the end.
Thanks, Lainey. I'm going to go ahead and pop my slides up here. Thank you to the ASRA panel members for joining us today and for inviting me to be part of this presentation. Stephen Porter and myself will be handling this last part, and I'm going to handle this a little bit more like a panel discussion as opposed to straightforward presentation. I was taking some notes during the other panelist discussion of things that I think might be interesting to elaborate on, and then I'm going to ask opinions of my fellow panelists on some of these topics that we're gonna bring up. So what we're talking about is what is the future of EPAs, and so everybody can see my slides. Yes. Okay. Good. Then I'm going to talk about, instead of what's the future, I'm going to talk about what's the now. And I've had the opportunity to participate in several seminars put on by the ACGME and the American Board of Medical Specialties. So they got together and they've been doing a series on competency-based medical education. And at these conferences are representatives from each specialty's RRC, their residency review committee, as well as their board members. And so it's not all of them, but there's a good sampling for at each table for each one of the specialties. And the purpose of these meetings, at least in my interpretation of them, is to really educate the RRCs and the American medical boards on the importance of competency-based medical education, what it is, and what the ACGME and the ABMS want the different programs to do. So it is clear from these meetings that they are pushing the concepts of competency-based medical education and that they want to see greater and deeper implementation of competency-based medical education at all of the specialty levels. So I think, that's really important. They haven't come down to say that the RRCs have to create requirements, or they haven't said this is a requirement, you have to do EPAs, you have to do X, Y, or Z. But they're really telling the same story, essentially, that Addie told, that this is where we need to head. And so I think Europe is a little bit further along. Certainly Canada is, and even Australia and New Zealand are a little bit ahead of where the United States is. But we are definitely, the ball is rolling. And so I think and it's rolling, starting to pick up steam. So I think all programs are being challenged now to consider how to revise their residency program requirements, and also the board certification process to take into account competency-based medical education. Now, there's variability across the specialties. Some are ahead, and they are participating in different ways because, as I said, there are more guidelines, there's no requirements. So, for example, surgery has developed EPAs for the entire specialty, and that those are being deployed residency programs, all the residency programs. Whereas in some other specialties, maybe there's a pocket of programs that are using EPAs. And I'd say that's the position that anesthesiology is in right now. We don't have any joint development by the RRC and the boards on competency assessment tools, but there are a couple of groups that have moved ahead to try and develop those competency tools. And you heard about one from Lainey, and also Addie has been a developer also of these kind of tools. Now, one thing I will say, though, about EPAs is they are only one type of competency assessment tool. There's many other workplace-based assessments out there, but I feel like, if you ask me my crystal ball now, I think the community of educators in medicine is beginning to coalesce around EPAs. So it seems to be the workplace-based assessment that has become a little bit more dominant than many of the other workplace-based assessments. So that's going to be my first question that I'm going to throw out to the panel. And I'm going to start with Addie. And Addie, what do you see? And I think you of course well aware that there's lots of different tools out there. Tell me about, who's fighting for the top, being the workplace-based assessment that is the most deployed.
So first, I need to make something clear that EPAs are not a tool. EPAs are tasks, and to assess these tasks, to assess an EPA, you can use different tools. So the most important tools that are used for assessing EPAs are direct observation. You can call them DOPS or mini CX or whatever you want. I'd rather would go for something like field notes, just a simple note on an observation you made with a trainee, like direct observation. Then case-based discussion or entrustment-based discussion is the second thing. The third thing is assessment of a product. So you assess maybe a documentation of a patient encounter and make a decision of a level of supervision based on that document. And the third thing that is not for daily usage, the prior three are really meant for daily use. But the fourth thing is longitudinal observation in the workplace, which results in a multi-source feedback. So those are the magic four that I would actually promote. And I know you have been working with OSCEs as well. I'm not a big fan of OSCEs. I'm already happy with the 4 workplace-based assessments and maybe add some theoretical exams.
But as a point of clarification, though, I think there is there is, more and more push that EPAs are the representation of the thing at the workplace, which will be assessed by these tools. There are lots of other things that could be used, but I feel like EPAs are becoming much more common.
I agree.
And not the primary form of things that people are assessing with their assessment tools.
Yes, I agree. And I think that's because it just makes sense to especially for those faculty and maybe even trainees who are not really keen of medical education. It just makes sense to look at tasks instead of many different competencies and whatever a competency might be. So it's easy to grasp. It's a task, and we observe somebody performing a task. So that's kind of an intuitive thing.
Thanks, Addie. Yeah, I'd say that comment is sort of related to milestones, which are the very specific things to look at, but they don't look at a holistic view. Well, I'm going to bring Stephen in now. And Stephen, the thing that I'm going to get you kicked off with is that there is an issue now within the medical education community about longitudinal assessment and about the transitions as you go from one thing to another. So one of the problems that's currently in the United States, at least, is that when we get a new fellow, there could be quite a bit of variability in where the fellow stands on a variety of these EPAs or different skills and attitudes. And we don't know that. And sometimes it takes us a little bit of time to try and figure that out. So Stephen, can you talk to us about how you might see EPAs as being useful in what I'm going to call the transitions of training?
Thanks, Glenn. I think it's a tough question. The reason I think it's particularly tough for us in our field is that our fellowship is 1 year, right? So it's super fast, and that makes it really difficult, especially if you have more than one fellow at different entering skill levels of different things. So you may have 2 fellows, you may have, some programs have many, but I think a lot of programs have 2 fellows. And if the fellows are asymmetric in terms of their experience levels, but your teaching didactics are set up to teach them at the same time, at the same progress, the same level, you have kind of built-in problems, right? Mm-hmm. Because you're saying, I expect you both here, and there's some asymmetry, but our education is based on this. And because it's 1 year and we have finite time, we're going to teach like this. And then you have kind of almost permanent asymmetries. Now, I think where the EPAs can come in is they can help delineate in a very specific fashion what the asymmetries are. Because many faculty who are not, I would say, not really interested in this, or it's not their area, and again, not everyone has to be interested in everything, that's fine. they just want to throw their hands up and say, I can't teach this person's bad, right? That's not true, right? They may have areas that need improvement, and to allow us to focus on those areas, when you can start categorizing the actual EPAs, you can start to tease out and say, oh, you know what? It's really just like the pre-op eval for someone having a peripheral nerve block that they're really struggling with, because they didn't have to do that much in residency. And so allowing you to identify those things, and just if I could backtrack a little bit, I think one of the benefits of this project, or these projects, I should say, is it's really helped me think about, I would say, how in the dark I was prior to looking into this about educational assessments. Because I can think about so many times, like meeting at the clinical competency committee or doing an evaluation a month, 2 months after encountering with things. And that's the basis for like the documentation we give the trainee about, like, here's what we think you're doing. I did this because someone said I had to have this form done by the next day. It was based on 2 months ago's work and all that stuff. It's ludicrous, right? But we have to give them some stuff. And you go to the meetings and there's anchoring, right? They just had an event the day before. That's all the CCC talks about. It has nothing to do with the previous month, 3 months, all this stuff. So being able to do these on the fly in real time, specifically, like I'm just going to give you one example, then we'll go to Dr. Marty. I had just thinking out loud. I had a trainee who we had to do something that was like, again, not everyday task. Like a patient needed antibiotics. Now, when's the last time we prescribed antibiotics, right? So the fellow, who's not a resident where where we are, had to learn, like, how do I order antibiotics and stuff. It's a very simple task, but for professionally, it involved having to ask questions, follow through on things, make sure like the script got sent, all that stuff. So there are ways to evaluate that task using the things that, like the special assessments that we created, that I would not have been able to, and I could do it in that day and talk about that event in a way that probably would have been lost if I had to do the evaluation a month later. And I think I'll pause there and go to Dr. Marty.
Yeah, so thank you, Stephen. That he's really pointing out a key feature of programmatic assessment is that it is frequent and it is timely. You don't rely on just an end of rotation or those types of assessments, that you're really relying on a lot of micro assessments over time that then give you a picture. But Addie, do you care to comment a little bit about on my thoughts about what we call the warm handoff? Are you guys getting any kind of warm handoffs in your area?
Warm handoffs is kind of feed forward situations, right? Is that correct? Is that what you mean?
Meaning that I know where that, so right now when a fellow arrives, I don't know anything about them, and they essentially, we learn about them in the first month. And if you have a lot of faculty, then each of us are only getting a little piece of the elephant. Yes. But the concept of a warm handoff is that from residency to fellowship, they would give us, here's all the competencies for, or, these are the competencies for this particular training. Here's where they're strong. Here's where they're weak. This is where you might be able to focus on, so that's the concept of a warm handoff. And if you received one, what would you do differently?
Yeah. So, I mean, it is essential to have warm handoffs, really, to also tailor our resources as educators to the actual needs of the trainees or of the fellows. I mean, you need to know where they are when they arrive. The situation here in Switzerland is we're only getting there. There's no law or something that prohibits this kind of warm handoff things. Like in Canada, sometimes they have the problem with feed forwarding is even not allowed. We don't have that situation. So the ideal situation would be to have an EPA competency profile where you have for every procedure, for every EPA, you have your level of supervision right there to present to your supervisors at the workplace, or even for the program directors to start designing your educational experience in your institution. So I think that's essential for programmatic assessment and for efficient and motivating training. and EPAs bring light. I like Stephen's expression that he was in the dark before the era of EPAs. And I really think EPAs bring light and are the diagnostics of what people need. And now we can have the therapy individualized, what they actually need to know and need to learn.
Very nice. I'm going to turn to something a little bit different, which is sort of, again, the now that's happening is that, you know, whenever these things are released, there's often, you know, some time that they need to be out there in the wild so where people can see them, and they need some sort of modification or adjustment over time. So there currently is a pilot that's taking place for EPAs, and it's broader than the 8 programs, I believe. I'm going to toss this to Lainey, but Elliot Higgins at UCLA and Rob Maneker at Columbia University are leading an effort to collect data on the utilization of the EPAs that Lainey has described and the assessment tool over a year, I think. And Lainey, do you have any comments about that pilot?
You know, I'm not directly involved in that pilot this time around, so I don't have any huge comments about it. But I think the one thing that I will bring up that's just interesting that you and I have talked about, Glenn, and Stephen, you may have more to say here, but is that I think like the biggest thing with these is that we talked about not having a great gold standard in terms of comparing how these assessments do against existing assessments, because as we've talked about, there's a lot of flaws in the existing form of assessment where there's all this lag time before you may assess a trainee or something like that. So I think it'll be really interesting to see what comes of this, but then also difficult to compare it to the existing form of assessment that we're using. But that's the one comment I'll make about it.
Yes,
Stephen,
I know to jump in. Yeah. So
yeah,
what
I
I
know
would
you
say
know about this. So
it's roughly 8, could be 9 programs that are trialing the EPAs that we developed for our project. And I just want to say, like, first of all, Dr. Woodworth just published like 2 days ago, yesterday. It's out now in Anesthesia and Analgesia, an article about core program EPAs development and assessing the EPAs. One of the beautiful things about the EPAs that we came up with is they're not perfect, right? They're not supposed to be perfect. They're supposed to be developed by people whose head is in the game. I'm not like an expert in this. I live it. So we come up with a model and then we test it and see how we're doing. And it may be after the first year. Actually, it should be after the first year that there are changes that need to be made. Things need to be cut out, added, modified. And that's, I think, what your article, maybe you could talk about your article next, about like how the assessments can be either improved or the goal of kind of iterative improvements.
I think what I'll say is that people should reach out to Rob or Elliot Higgins, and it's Rob Maneker at Columbia and Elliot Higgins at UCLA that are running the pilot, because I'm sure they're more than willing to have more participants. Now we've got just a few more minutes before we want to open it up to general questions. So I'm just going to throw a couple of things out there, and I'm going to call it in the near future that we're going to need to address. And the first is CCCs are not really prepared to deal with EPAs yet, or the assessment tools that go along with it. And the part of competency-based medical education and programmatic assessment is that you have defensible decisions for transitions of training. And so the idea is that with all of these EPAs, and as Addie pointed out and Stephen pointed out, that if we have a light that's shining in all of these different skills, that we would have a lot of assessments that would be able to back up why we think a trainee is at a certain level and why they're ready to make a transition, and whether it's from UME to GME, GME to fellowship, or from fellowship to independent practice. So I think there is going to be a lot of focus in the next couple of years on CCC function and how CCCs operate and how they deal with this information. And sort of related to that is, let's say we have a lot of tasks, as Addie's system has pointed out and Lainey has, that we don't actually know if we're going to say, well, do you need to be the whole pie, or can you have part of the pie? Or are there certain of these tasks that you absolutely have to be able to do before we let you go on to the next transition? Or in the Lainey system, there's graduation targets for everything. Does that mean that you have to meet all of those graduation targets to move on to the next transition? And I think that's a current hot topic that's going now and will be determined in the next several years about how that's handled. I see Addy shaking his head. So Addy, do you want to jump in and make any comments about, I don't know if you have a clinical competency committee in Switzerland, but that's our method of assessing here.
Yeah. We do not call them CCCs at the moment yet, but we are moving towards more formal CCC processes. But the thing is, it's exactly the human element in CCCs that is still valuable. I think not everything can be replaced by algorithms and just data that we draw in. There might be still some value for human decision making based on a bunch of data which is displayed in a meaningful, intuitive way, and then a CCC can make a decision, even though not everything is perfectly documented, but still it gives enough evidence to make that decision. So I think
there's a lot of research that supports the group decision making. But I think what this, in my experience with dealing with CCCs and different ones than not just the one at my institution, is they've been dealing with a paucity of data. The data that they get today is usually something bad has happened, right? You know, there's something bad about a resident or some problem. That's the stuff that tends to come up to a CCC and gets discussed. There isn't discussion around, you know, oh, well, Glenn Woodworth is here and that's good enough, but maybe he wants to get to here. And so what could we do to try and help them do that? No, we're really trying to only look at the bottom. And then also, as I mentioned, the paucity of data. So the CCCs are going to have to rethink how they operate now that they are going to have all this data, hopefully lots of data, and with a good data display. So I think those are two areas. Well, I've taken up a lot of the time here at the end, and I want to make sure that Chris has an opportunity to ask some questions and redirect us and see if our studio audience wants to participate.
Yeah, there is a question asking about how these EPAs then are used for providing evaluations for the learners. So are these something that you would deploy on a daily, monthly? Would it be only every 6 months? And then if you do have, you know, feedback that points out that maybe this learner is in need of extra assistance, you know, how do you approach those with that learner to kind of encourage them to move forward and hopefully not, you know, alternately discourage them?
Go ahead,
I can
pointed
take
to somebody.
I see you want to talk, go for it.
I can take the first part of the question, and then if anyone wants to add about the second part, just given my role. But for the my tip report aspect, at least for the project that we developed, they're meant to be used on a daily basis whenever any of those skills is deployed in clinical practice. So I didn't include screenshots or anything from the app itself in my presentation, although you can find it if you look at the paper that we published. But it's very user friendly, and it's really just meant to be used on a daily basis.
I mean, is it something though that you would use as a part of a 6-month evaluation, you know, where you would go back and you'd say, okay, gosh, you know, you've gotten all these evaluations that, you know, were either poor or, you know, they're showing growth, or here's where it's showing growth, but these are the things that you need to work on. Do you think that's kind of the ideal way to then kind of try to use these things then with our learners?
Shall I jump in?
Absolutely.
I think yes, of course. If you have the ideal world of daily assessments, and my personal record is 6 assessments or 7 assessments per day for my trainees in my OR. And I can't say no because I invented the tool. So I was kind of stuck in my own problem. But I was managing to do like multiple assessments per day, and then you can actually draw some graphs and you can see how they grow on each EPA. And of course there are some bad Monday mornings, and they will have a dip or something. But in the end, you will see a constant growth as they learn more things and get more confident with the EPAs. And it's really nice to see that graph evolving, and the person behind the graph, of course.
I'll mention that one of the goals of CBME and why it calls for frequent assessment is exactly that. You know, if I'm assessing a trainee on a Monday and my dog died and my wife left me and I just found out I'm being audited by the IRS, I probably don't give the same evaluation on other days. And similarly for the trainee, they could have similar things going on. So, and there's also bias in the system. Glenn Woodworth could be a super hard rater, and Stephen Porter could be, you know, really, you know, everybody's fantastic. And so by having a high number of diverse assessments is going to give you a better picture of the trainee than just a sampling of just one or twice or three assessments in a whole quarter. And I'll bet the vast majority of CCCs get maybe 10 comments, you know, in a quarter. And so you are making significant decisions about a trainee's advancement based on 10 data points. And as I mentioned, some of those may be the negative data points or they're the milquetoast data points. So they're not actionable, certainly in any way. So that is the goal of CBME, that they are frequent, and daily, I think, is a very reasonable goal. Now, I will say that when we implemented residency level EPAs and an assessment tool for them, we saw a 3 to 4-fold increase in the number of assessments that were being submitted by faculty. So it was a substantial increase. Unfortunately, I would like to say that it meant that all of a sudden we brought in new people into the tent that weren't filing assessments, you know, that weren't the diligent ones. And I would say there was some of that. I was surprised about, like, because I can only tell that in my own program. Oh, I see so-and-so filed an assessment. That's cool. I've never heard him say a word, you know, ever. But the truth of the matter is it did bring some people in, but it also meant the people that were filing your other assessments were also the ones that, you know, really adopted more. But that is the goal. We need more data, again, as I said, to make reasonable and defensible, transparent decisions on transitions and training.
And there are two questions related to that, right? Maybe you wanted it to point that out, Chris. So there are two questions. One is from Garrett, and one is from anonymous participants. So how to getting buy-in from resistant faculty members, right? I mean, I had the philosophy, I wanted to change the world, right? Everyone needs to be a great assessor, but that's not going to happen. So there will always be those who will never use the tool, however good this tool will be. So, and that I made peace with that. So it's okay. But at least for those who would want to give more feedback, more ratings, they should have an easy way to follow through a workflow of a mobile application. So and the most important thing of getting buy-in is to close the loop. So the assessment data point that goes into the system should make a difference in your teaching tomorrow or the day after tomorrow, because you can rely on your colleagues that have documented things as well. And you don't start from scratch every day. You have a new trainee in front of you. So it's actually really helpful for faculty and for trainees to have that transparency of where the people are and how to support them.
I'm going to jump in and answer a little bit about that anonymous attendee that asked the question about microassessments. In general, we did not see that there was a spike in assessments and then that the number leveled out and went back to baseline. We did see a spike, but it's tended to stay a little bit higher, and it definitely stayed higher than whatever the prior assessment system they were using. In talking to a number of programs, I've seen them use a variety of approaches, anything from gamification, like Stephen Porter had the most assessments this month. He gets a Starbucks gift card, you know. To the punishment side of the equation, which was you have to have this number of assessments filed by this amount of time, otherwise that's going to come up in your faculty evaluation, something like that. Most of the systems also provide some sort of, I don't want to say the gaming part, but notification. They'll prompt people to do assessments so that they're timely. It doesn't really help if I do assessment 2 weeks later and I really don't even remember what happened. And there's some other really interesting research going on. And I have to say our group is doing some interesting work on if faculty knew that the quality of their assessments were used in some way, like Addie said, for the next person to do something with the trainee. Well, we're looking at sending automated content to the trainees. And based on the analysis of the text that you're putting in your comments, the more rich that text is, the better we match the content to what we can push out to the trainee. So that's another aspect of motivation for filling out good feedback. And then lastly, some programs, and particularly in undergraduate medical education, have gone to, well, you know, it becomes more resident driven instead of faculty driven. The residents want to get their belts in all of these different things. They want to demonstrate that they have these competencies because they want to graduate. You know, there may be some sort of thing that they have to meet X, Y, or Z to graduate. So in those programs, it is very resident driven. Now there is some cherry picking, you know, I did a great A line today. Chris, can you evaluate me? You know, when I do one that sucks, nobody mentioned it, you know, let's just move on. But I mean, those are the variety of things I've heard about trying to get traction with any type of assessment.
I know we've used a variety of carrot type approaches where, you know, there's a monthly leaderboard, and then also, you know, the number of these evaluations that you fill out, you know, if you meet a certain threshold, that's used as a component then of your academic merit, you know, compensation at the end of the year. Have you ever thought about using this as a way of the learners then to evaluate the education that's provided to them? That, you know, on a daily basis, there would be this 360-degree process where the teachers could be evaluated and then either encouraged and incentivized to improve, or alternatively have areas of deficiency pointed out to them.
You know, I think the advent of new technology, particularly natural language processing, artificial intelligence tools, are making it able for us to actually mine the data and look at the quality of, there's been work on looking at the quality of assessments and giving you feedback on the narrative assessment that you put in. So, and everybody does it differently. One of the things you have to do, though, is that will help adoption in the tool is if you make that feedback useful. And Addie didn't mention it, but he's a leader in using this as a stimulus. It isn't so much that you know, what went down in that assessment, but that it stimulated a feedback conversation about whatever it was that you chose to evaluate the resident on or the fellow on. We're going to talk about your preoperative evaluation. Well, that's a whole conversation that we might not have had, as opposed to good job today, you know. But we're going to specifically focus on your preoperative evaluation. So I think, you know, we have to make it valuable. So the more that it stimulates feedback, that the feedback that you put in is rich and actionable and does something for you, the trainee, you know, I think it helps. Personally, what I do is I put my coaching tips in the EPA, in the comments. I say, well, this is what we talked about today. We talked about this is how you can improve X, Y, or Z. We talked about doing this. We talked about doing that, and then becomes something they can look at later.
So it's easy from like a technology standpoint that you can add a small survey at the end of a rating process to also evaluate the teacher or the supervisor. And I think it's fair. If we rate the trainees, they should be able to rate ourselves. But then we need to make sure that it's not kind of, I give you a good grade, you give me a good grade as well. So it's not a trade-off, but it's a genuine interest in helping each other grow as professionals. And that's probably quite an idealistic view, but certainly hope that we work together towards this future. And can't wait to see that.
All right. Well, even, you know, just some recognition, you know, there's some faculty where, gosh, you know, they really bring their A game. They brought in, you know, some toolbox PBLD that they discussed with the resident during that all day long trainee, you know, versus, you know, maybe sometimes other faculty are less present than throughout the day. And so then just kind of recognizing, you know, hey, that extra effort, we appreciate it.
Mm-hmm.
And then hopefully there's some positive feedback that then kind of helps to kind of reinforce that sort of activity among our teaching colleagues.
Yeah.
Okay, so I think we are close enough to the end that we'll kind of wrap things up here. On behalf of ASRA Pain Medicine, we would like to thank you, our panel, and then everyone who's tuned in here today for your participation in today's event. That concludes our program. A couple things to keep in mind, though, coming up very soon here, November 10th through the 11th in New Orleans is the 22nd annual Pain Medicine meeting. The Advanced Perioperative Point of Care Ultrasound course is going to be December 2nd through the 3rd in San Diego. And then speaking of San Diego, the 49th annual Regional Anesthesiology and Acute Pain Medicine meeting is scheduled there for March 21st through the 23rd. Our next Hot Topics webinar, at least on the regional anesthesia side, will be in December, where we will have leaders from the ASRA LGBTQ TSIG discussing perioperative management and the approach of transgender patients presenting for surgical procedures. And with that, have a great night, and thank you all very, very much.
Thank you very much. Thanks.